Okay, a pharmaceutical research company is studying the effect of nascent peptide on beta-2 adrenal receptors in female mice. During the experiment, the nascent peptide is injected into each mice, and the effects of nascent peptide is observed to be similar to that of epinephrine on beta-2 adrenal receptors. Which of the following physiological effect is most likely to be increased in these mice? Okay, so this is a relatively straightforward question. um, they want to know simply what is the function of beta-2 receptor. Okay, beta-2 receptor. Or the interaction between epinephrine and beta-2 receptor. What's the end result of that? Or what's the physiology of that? So this nascent peptide that they're talking about is like epinephrine and it acts on beta-2 receptors. So when the two interact, what happens? Well, for us to answer the question, let's know what is beta-2 receptor. Okay, so in essence, they're simply asking for beta-2 receptor function. That's all. Function. So what is the function of beta-2 receptor? That's all we want to know. So beta-2 receptor is primarily found on smooth muscles. So it causes, beta-2 receptor cause smooth muscle relaxation. It causes smooth muscle relaxation. Okay. So whatever smooth muscle will have beta-2 receptor on them, it will cause that muscle to be relaxed. We know that beta-2 receptor is found on bronchiole, especially because of the albuterol use, right? So if it's found on bronchioles, therefore relaxation of bronchioles will lead to bronchodilation. Bronchodilation. So that's one. Beta-2 receptor is also found on the smooth muscle of uterus. So it leads to uterine relaxation. Usually you can use it to prevent premature labor, premature birth, right? Okay. Beta-2 receptor is also found on blood vessels. I'll just say vessels, but this is blood vessels. Okay. Now it's not found on all blood vessels. It's primarily found on coronary arteries. Coronary arteries. So it increases blood flow to the heart. But again, it's not the main regulator of coronary artery blood flow. The main regulator is adenosine, right? It's a locally, see, coronary arteries are locally monitored. So blood flow through coronary arteries, locally regulated. But in the case of flight or fight mechanism, when you have increased epinephrine secreted in throughout the body or adrenaline, you know that it causes vasoconstriction in the GI because it's alpha-1 receptor, but in the coronary and skeletal muscle arteries, it causes dilation. That's because of the beta-2 receptor. So skeletal muscle. Skeletal muscle. This is good to memorize. These are the exception to the rules. So blood vessels in skeletal muscle and coronary arteries, if you it causes what? Vasodilation. So I'll say therefore it causes vasodilation. Only in this, as far as we know, okay? Or at least the important things. There might be more to it. Okay. In terms of metabolism, beta-2 receptor is also found, for example, on the liver and so forth. So it increases glucagon. So beta-2 receptor responds to glucagon. Glucagon is what activates it. Okay. So beta-2 receptor responds to glucagon and glucagon activates it. So increases glucagon secretion from alpha cells of pancreas. So pancreas also have beta-2 receptors. Now, if you get confused, the best way to remember is beta-2 is adrenal receptor or adrenergic receptor, sorry. It is adrenergic receptor. Adrenergic receptors are component of the flight or fight mechanism. If you're so scared that you have to run or you want to fight, you definitely need more glucose to reach your brain, and therefore you must have glucagon. Glucagon is the one that increases plasma glucose levels. So you can even fill in the black logically. Okay. So increase glucagon secretion. If you increase glucagon secretion, guess what? Glucagon will increase glycogenolysis. Glycogenolysis breaks down glycogen into glucose. It also causes glucagon will further cause lipolysis, right? Breakdown of lipids, because a lot of organs, including the heart, uses fatty acid as a primary source of ATP. Okay. So further, it glycolysis, lipolysis. You can also say that increases fatty acid oxidation. Fatty acid oxidation. So glucagon is actually a good hormone in terms of weight loss oxidation. Okay. One more thing, glucagon promotes, okay, it promotes intracellular shift of potassium. Intracellular shift of potassium, which is important in, for example, in diabetic ketoacidosis or hyperkalemia. You can use beta 2 receptor agonist. Okay, so so these are the function of beta 2 receptors, and epinephrine interaction. But remember, our question is talking about a new agent, a new peptide. In this case, nascent peptide. Nascent peptide means newly synthesized peptide that acts just like epinephrine. It activates beta 2 receptor. If it does so, what will happen? Okay, what are the effects of this? Now we can go to the choices to see which of these choices make sense. Myocardial contractility, no. Bronchoconstriction, no. It causes bronchodilation. Uterine relaxation, yes. That would be our choice. Okay, let's see anything else. Pilomotor, no. Papillary, no. Okay, so we said it's found in uterus and causes uterine relaxation. So this is our choice. If we have memorized these and understood it, we should just strictly right away go to the answer the question. Let's answer the rest of them why the other ones are wrong. Myocardial contractility is the function of beta 1 receptor, okay, not beta 2. We're looking for beta 2. The question is not about beta 2. A talks about beta 1 receptor. Beta 1 receptor is found on the heart and it's responsible for increasing heart contraction, increasing heart rate. So beta 2 receptor activation by epinephrine will lead to increased contractility and increase in heart rate. Okay. All right. Bronchoconstriction. We already know that beta 2 is found on bronchioles, right? It's found on bronchiole, but it causes bronchodilation, not constriction. Okay, not bronchoconstriction. Bronchoconstriction is the function of M3 receptor, muscarinic receptor. This is why for asthmatic patient or chronic bronchitis patient, you can use ipratropium, which is M3 antagonist. Okay. All right. Uterine relaxation was our option. Pilomotor contractions, these are the muscles that are responsible for erection of hair when you're cold, afraid, and so forth. This is regulated by alpha 1 receptor. Okay. Okay, pupillary dilation. Pupillary dilation is also alpha 1. Now, look, pupil have circular, so let me just say pupil. Pupils have circular muscles. There you go, these are the circular muscles. And then they have radial muscles. These dark ones are the radial muscles. Okay, so radial muscles, when you contract radial muscles, the pupils dilate. Okay, so the radial muscles have alpha 1 receptor. So pupil dilation is alpha 1. Okay, fatty acid synthesis. Look, fatty acid synthesis is mostly induced by not beta receptors. Beta receptor will increase fatty acid use, fatty acid oxidation. Okay, not synthesis, so that would be wrong. Okay, so hopefully this answer your question. Let's move on to next. Okay, so next question. Next question says 40-year-old woman comes to the physician because of 12-month history of increasing fatigue, cold intolerance, dry cool skin, depression, weight gain, and occasional constipation. This constellation of symptoms in a 40-year-old female should immediately make you think of hypothyroidism. hypothyroidism. Okay, almost. But if it's a 40-year-old female with hypothyroidism, I'm going to think of autoimmune hypothyroidism or Hashimoto, which is the most common cause, number one cause of hypothyroidism. But anyhow, you have to know the thyroid function. On physical examination, the thyroid gland is firm. It's firm, nodular, diffusely enlarged. Tissue biopsy of the thyroid gland shows diffuse infiltration of lymphocyte. Which of the following is the most likely diagnosis? Okay. So again, this constellation of symptoms, at least one thing I am coming to the conclusion. This is hypothyroidism. So it will make my life easier. Hypothyroidism. Okay. Why? Because there is fatigue. There's cold intolerance. And there's dry, cool skin. This patient's having all these things, and depression and weight gain. Constipation. Okay, so this constellation of symptoms should always make you think of hypothyroidism. Remember, in hyperthyroidism, you have diarrhea. In hypo, you have the opposite, which is constipation. In hyperthyroidism, you have weight loss. In hypo, you have the opposite, which is weight gain. In hyperthyroidism, you have anxiety. In hypothyroidism, you have depression, which is the opposite. So if you just know hyperthyroidism, you can go the opposite with hypo. In hyperthyroidism, you had hot, moist, soft skin. And then in hypothyroidism, you have dry, cool skin. In hyper, you have heat intolerance. In hypo, you have cold intolerance. Okay, in hyperthyroidism, you have more energy. In hypothyroidism, you have lack of energy or fatigue. Done. Boom. You should immediately make your diagnosis of this one. This is hypothyroidism. Now, but hypothyroidism has many causes. It has many causes. The problem will come to that. Okay, so it's hypothyroidism plus this person has firm, nodular, diffuse, enlarged thyroid. Okay, second thing is, so that's on the physical exam. In the non-biopsy, what do you find? Diffuse lymphocyte infiltration. Okay, all right. So the thyroid gland is diffusely enlarged, and it's firm and it's nodular. But in addition to that, there is infiltration of lymphocyte. If it was infiltration of neutrophil, I'll think of acute inflammation. If it was infiltration of macrophages and or giant cells, I'll think of viral infection. When it's infiltration of lymphocytes, primarily B cell, let's say, B and Th2 cells, which are lymphocyte, I'll think of autoimmune. So now I'm reaching a conclusion. This is autoimmune hypothyroidism. Autoimmune hypothyroidism. And of course, the most common cause of autoimmune hypothyroidism is what? Hashimoto. So my diagnosis overall should be Hashimoto. Hashimoto thyroiditis, okay, or Hashimoto's disease. Now, and if it is Hashimoto, what do we have? There are antibodies in a Hashimoto. Those are known as anti-thyroid peroxidase antibodies. Well-known antibodies. They're positive, these patients, for those. Or they have anti-thyroglobulin antibodies. Thyroglobulin, which is a protein that carries thyroid hormone in blood. Antibodies, positive. So look for those things. You can also have anti-TSH receptor antibodies, destroy the TSH receptor, not like TSH stimulating antibodies, TSH destructive antibodies. Okay, so this is Hashimoto for me. Let's look at our choices. In our choices, we have chronic autoimmune Hashimoto thyroiditis. A should be the answer. Okay, Now let's go look at B. Why is B not the answer? B talks about diffuse toxic goiter, which is Graves' disease. Graves' disease is not hypo, it's hyper. It's hyperthyroid. It's hyperthyroidism. So we're looking for hypo. So unlikely, B is unlikely. Simple, it's hyperthyroidism. I don't even have to look into it further. Granule. And you know, for Graves' disease, you have TSI, thyroid stimulating antibodies, which stimulates the whole thyroid gland, and it leads to hyperthyroidism, and then ophthalmopathy, strabismus, and blah blah blah. Okay. C is talking about granulomatous thyroiditis. Granulomatous thyroiditis means, you know, granulomas are made of T cells and macrophages. Usually, this is because of viral infection. Okay, so granulomatous thyroiditis is also known as Dequavrian. Dequavrian. Thyroiditis, which is painful. Let me change color. Which is painful, tender. Thyroid gland that's enlarged. So the thyroid gland is enlarged. It's painful. It's tender. But in our case, the thyroid gland was what? In our case, the thyroid gland was firm, nodular. Okay, not painful. It was firm, non-painful. And in the case of this, it's very tender. So you'll be looking for those things, which we don't have. So Dequavrin is a viral infection thyroiditis, so this is unlikely. In granulomatous thyroiditis, or in general, acute and subacute thyroiditis, always the first symptoms are hyperthyroidism, followed by hypothyroidism. So look for those things. So in granulomatous thyroiditis, I should expect hyperthyroidism, followed by hypo, but this is unlikely, so not a good choice. Papillary carcinoma. Papillary thyroid carcinoma is one of the most common thyroid carcinoma. 75% of all thyroid cancers are papillary carcinoma. Okay. And this cancer does not produce thyroid. If anything, it will be hypothyroidism. That's true. I'll be looking for weight loss in terms of symptoms. And I'll be looking for firm mass, not nodular, single nodule. Okay, not nodular, not multiple nodules, not diffusely enlarged. So there will be one area of the thyroid gland that's palpable and it's enlarged, and it'll be mobile with swallowing. Okay, so if this was that's what we'll be looking for in terms of symptoms. It'll be neck mass. So there should be a neck mass. This neck mass is mobile with swallowing. It's firm, it's non-tender, it's painless. Okay, and it moves with swallowing, which I don't have in this question. In addition to that, on biopsy, I'll be looking for orphan antinuclei, and psammoma bodies. Psammoma bodies, and orphan antinuclei. That's what I should be looking for if I expect this to be papillary carcinoma. Okay, but again, there's nothing here in papillary carcinoma is unlikely to affect thyroid hormone production to that much unless the whole thyroid gland is destroyed. Okay, but it'd be, and the other thing is the thyroid gland will not be enlarged diffusely. It will be just one area of the thyroid gland where you feel the mass. Toxic. The next one is toxic multinodular goiter. Okay, toxic means hyperthyroidism. Toxic in this context means hyperthyroidism. I know this is not hyperthyroidism, so right away I'm going to say no, this is not the answer. Okay, so hyperthyroidism, that's the word toxic means. Multinodular means not diffusely enlarged. It means there's nodules. Look, if this is the thyroid gland, there's a nodule, 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 there's a nodule here. This is multinodular goiter. Compared this to diffusely enlarged thyroid gland. Diffusely enlarged thyroid gland will be enlarged everywhere. Okay, it will be enlarged everywhere. The whole thyroid gland will be enlarged. All right. So in this case, that's not a that's not an issue here, right? Okay. So let's go. So that's okay. Let me change my pen. So we're looking for the multinodular goiter, and with hyperthyroidism, that's right away another issue. Viral thyroiditis is the same thing as granulomatous thyroiditis. It'll be pain for enlarged, diffusely enlarged thyroid gland that's very tender. So that's not an option. So the option, the best one is A. Okay. Okay. And the name of the toxic multinodular goiter is Plummer's disease, just if you want to know. Okay, so this next question is a 40-year-old woman comes to the physician because of 2-month history of confusion, amnesia, muscle spasm, occasional tingling and numbness of her fingers. It's a woman, I said his. Okay, so that should be her fingers. Blood pressure is 120/80, pulse is 70, temperature is normal. Physical examination shows dry, scaly skin, dry hair, positive Schwastic sign. Okay. Which of the following is the most likely diagnosis? Okay. When I look at these symptoms that is confusion, symptoms of amnesia, spasm, or let's say muscle spasm, tingling, numbness. When I look at this, in addition to the dry skin, should be dry scaly skin, right? So dry scaly skin. Okay. Dry hair. And Schwastic sign positive, which is when you tap the face with your finger and it goes through spasm. This is all signs of hypocalcemia. So hypocalcemia is our diagnosis. Okay, so our diagnosis should be hypocalcemia. In addition to that, look, you should know the calcium primarily stored in bones. So hypercalcemia can lead to bone fractures, weak bones and so forth. Calcium is used by major, all three muscles for contraction. So hypocalcemia can lead to arrhythmia, decrease in blood pressure. It can, in smooth muscle, for example, the GI tract requires calcium for contraction, peristalsis. So you should expect constipation, diarrhea in those patients. CNS and endocrine system requires calcium for degranulation of vesicles. So CNS signs could be like lack of calcium, confusion, amnesia, and so forth. And skin, remember, skin also requires calcium. So without calcium, skin can be dry and scaly and so forth, and the hair become dry. Okay, because certain enzyme requires calcium for its functionality as well. So calcium is a global electrolyte, extremely important. It's important for enzyme function, it's important for muscle contraction, it's important for neuron function or degranulation of neuron vesicles, it's important for endocrine system. It has so many functions. Okay, so this is hypocalcemia, and the general plasma calcium should be around, I think, 8.4 to 11 point something, 11.4 or 10.4, 8.4 to 10.4, if I remember correctly, milligram per deciliter. Anyways, so we know this is hypocalcemia, but then hypocalcemia has multiple causes. Let's talk about the causes of hypocalcemia. Okay, so cause of low plasma calcium. And that's what this question is asking, which of the following is the most likely diagnosis. Okay. Now, cause of hypocalcemia could be So the most important cause is either you have low PTH, hypoparathyroidism, right? Low PTH, that's cause one. You can also have hypocalcemia because of vitamin D deficiency. Vitamin D deficiency. You can also have hypocalcemia because of chronic kidney diseases. Okay. You can also have hypocalcemia because of low magnesium, hypomagnesemia. You can also have calcium because of acute pancreatitis, because pancreatic enzyme will consume a lot of these calcium. Pancreatitis. You can also have hypocalcemia, which is acute hypocalcemia, blood transfusion. Blood has citrate in it to keep it from um, blood transfusion, right? Because the citrate chelates calcium, right? Okay. And of course, one of the common causes of thyroidectomy. Thyroidectomy. Because thyroid gland not only have thyroid, but they also produce parathyroid. Okay, so depending which one is the cause of it, let's see if we have any of these choices in our options. And then if you need further, we can go over further information. Addison disease is deficiency of the adrenal gland. An adrenal gland produces cortisol, aldosterone, and androgen. So it's not responsible for PTH and calcium. Cushing is hypercortisolism, not related to PTH or calcium. Hyperparathyroidism produces too much PTH that leads to hypercalcemia. Okay, hyperthyroidism is related to thyroid hormone. Hypoparathyroidism, yeah, that is our option because this is the first one we discussed here. Hypothyroidism, okay. Now that we know that we have answered, let's rule out the other option. Okay, so our goal is first to answer the question. Addison's disease. Addison disease is adrenal insufficiency. Usually it's adrenal cortical insufficiency, which is considered adrenal failure. So what happens? There will be less cortisol. If there's no cortisol, that leads to hypoglycemia because cortisol causes gluconeogenesis, increases your plasma glucose level. Without cortisol, plasma glucose level drops, leads to hypoglycemia. Adrenal gland also, the cortex, adrenal cortex also produce aldosterone, right? So there will be less or decreased aldosterone production. Aldosterone is primarily responsible for maintaining blood pressure and plasma or blood acidity. So no aldosterone, meaning hypotension, and it will lead to acidosis. Okay, and of course androgens are produced by the adrenal cortex. Androgen is not going to cause any acute issues, but long-term wise, maybe amenorrhea or maybe like male decreased libido in children will have those effects. So you can look for those things. Okay, so unlikely to be Addison disease. Some of the most common causes of adrenal insufficiency are Waterhouse-Friderichsen disease, okay, or Addison disease, which is chronic. Chronic is Addison, acute is Waterhouse-Friderichsen disease. Okay, Cushing syndrome. In Cushing syndrome, there is pituitary adenoma usually, or adrenal adenoma that produces too much cortisol. So the end result is too much cortisol. Too much cortisol, this will lead to hyperglycemia, and it will lead to moon phases and truncal obesity and so forth. Okay, and wasting of muscle, weakness, bruising, the typical signs of Cushing's. But the main thing is in Cushing's you have hypercortisolism. Hypercortisolism. Whether you have low ACTH or high ACTH will depend if it's primary or secondary, or if it's lung cancer that's producing too much cortisol, or if there is, somebody's other conditions. Okay. Hyperparathyroidism, too much PTH. That's hyperparathyroidism, too much PTH. This leads to increase in calcium. This will lead to hypercalcemia, not hypocalcemia. We're looking for hypocalcemia, so that's not an option. Hyperthyroidism is clear-cut, obvious, that has to do with thyroid, and hypothyroidism has to do with thyroid, nothing to do with hypoparathyroid and with calcium. Hyperthyroidism for sure is not related. Okay, so hyperthyroidism for sure is not related to this, so I'm going to rule it out. Okay, so this will simply means increase in T3 and T4, but hypothyroidism is my second best option. Why? Because if you have no thyroidism, then you should look for thyroid gland. If you palpate the neck or do CT scan of the neck, if there's thyroidectomy done, then that will be a common cause. Thyroidectomy. Ectomy. So that's a common cause of hypoparathyroidism, and this can lead to hypocalcemia. But in this question, we don't have that. Okay, so we don't have any history of thyroidectomy. A young female, so most likely she has hypoparathyroidism, whatever the cause of hypoparathyroidism is. Okay, so this is good. Let's move on to our next question. Next question is a 22-year-old woman comes to the physician because of 8-week history of milky discharge from both of her breasts. It's not unilateral, it's bilateral, that's important. Her menstrual period was 2 months ago, so she has amenorrhea. She has no other complaints. Thyroid stimulating hormone. Okay, so I know these values, but if you don't know it, it's okay. You will always get a lab sheet on your exam. TSH is normal between 0.4 to 4, so this is normal. Follicular stimulating hormone is 5 to 25. Luteinizing hormone is 5 to 25, so these are all normals. Prolactin is usually prolactin is less than 25, so this is very high. So this person looks like hyperprolactinemia, and its signs and symptoms. Administration of 6-day course of medroxyprogesterone test does not induce menses. Brain MRI shows lesion in the pituitary gland. So MRI shows a lesion or a mass in the pituitary gland. Which of the following drug is most appropriate? Treatment. So what is the treatment of this person's condition? Let's diagnose it first. Our first goal is to diagnose. Okay, so this woman, 22, female, what does she have? She has galactorrhea, right? Galactorrhea, the milky discharge from both breasts, and she has amenorrhea. Amenorrhea for 2 months, no menses. Plus, she has prolactinemia. Prolactinemia. How do I know that? Because her plasma prolactin level is what? Serum or plasma prolactin level is 200. Okay, so therefore she has prolactinemia. In addition to that, she has a mass, so pituitary adenoma, a 6 millimeter lesion in the pituitary gland. So this is pituitary adenoma. Okay. When I have this combination of symptoms and signs and lab and imaging finding, there is no other option to say this is prolactinoma. Okay, so my diagnosis would be prolactinoma. Prolactinoma. Okay, so this is prolactinoma. So this is prolactinoma 100%. But if I get the symptoms of galactorrhea, amenorrhea, and prolactinemia, I'll be suspicious. What helps me make this diagnosis of prolactinoma is what? The MRI. But let's say prolactinemia. Prolactinemia, the main cause of prolactinemia are what? The main differential diagnosis of prolactinemia is antipsychotic use, right? Antipsychotic, like haloperidol, antipsychotic use. And it can be hypothyroidism. Yeah, hypothyroidism. Hypothyroidism. And the third one is prolactinoma. Prolactinoma. We said it's prolactinoma in this case is the cause. If it was antipsychotic, we should have a history of a person with psychosis and then use of antipsychotic medication. That's not the case. And if it was hypothyroidism, we should have a case of hypothyroidism, and this case is not a case. But just to tell you, um, TRH, thyroid releasing hormone. TRH stimulates, activates prolactin secretion. Okay, so TRH will increase prolactin. Prolactin then acts on GnRH. Okay, and it inhibits GnRH production or decreases it. So this is why when you have prolactinemia, it can lead to amenorrhea because of the inhibition of gonadotrophic releasing hormone. Okay, so anyways, we know our diagnosis. Now that we know our diagnosis, how do you treat it? Prolactin is usually regulated, prolactin secretion is usually inhibited by dopamine. So the best solution is dopamine. Okay, in this case, we have a dopamine agonist. That should be the better choice. Dopamine antagonists will increase prolactin secretion. So that's what antipsychotics do. Antipsychotics are dopamine antagonists. Oxytocin agonist. Oxytocin will increase milk secretion from your breast. So oxytocin is not a solution to it. If anything, oxytocin ejects milk from breast, not synthesis, right? Oxytocin antagonists will not help because the problem is not ejection of milk. The problem is prolactin, which makes milk in the first place, or breast milk, I should say. Serotonin agonists, antagonists, those are not needed. I mean, serotonin agonists for depression would help. Selective serotonin reuptake inhibitor, for example, for depression. So the best choice is A. Hopefully this was helpful. It's a very straightforward question. So first you have to diagnose, then do treatment. Diagnosis prolactinoma, and the treatment is what? Treatment is dopamine agonist, which is bromocriptine. Bromocriptine is the medication. Let me write it down. You can use bromocriptine. Okay, you can use this for it. All right, let's go to our next question. Okay, next question is: the 5-year-old boy is brought to the to the pediatrician's office because of brassy cough, fever, stridor. He is treated with a single dose of dexamethasone. The patient recovers completely. On the follow-up exam, the boy's parent asked the physician that a single dose of dexamethasone was enough to treat the patient's symptoms. The physician informs the parents um, that the pharmacological effect of the drug persists after the drug is eliminated from the body because of dexamethasone receptor chemistry. So something to do with the dexamethasone receptor chemistry. So what they're saying is, like, how is it possible? The parents are asking, how is it possible in a way that a single dose of dexamethasone was able to resolve this patient's symptoms, because generally people take antibiotic or medication for weeks or days. So they're saying it's just a one dose. The doctor's responded to them is, guess what? Dexamethasone, even though when dexamethasone is eliminated from the body, its effects remain because of its receptor chemistry. Okay, you as a doctor or as a medical student should know what receptor chemistry mean. Which of the following characteristics of the dexamethasone receptor is most likely the cause of the persistence of pharmacological effect? So you need to know the steroid receptor. Okay. Okay, so what about dexamethasone receptor is so unique that its effect can be remaining even the drug is eliminated? First, let's do this. 5-year-old, because I can change this question completely to a different answer. 5-year-old has a brassy cough. Okay, has fever and has stridor. And then he's given dexamethasone. And dexamethasone actually helps him recover. zone, which is a steroid. Dexamethasone is a corticosteroid. It's a corticosteroid. Remember, corticosteroids inhibit the phospholipase A2, therefore decreasing prostaglandin leukotrienes. Okay. So when I see this clinical scenario, all I have to change is the question, what's your diagnosis? You should know the diagnosis in this case is croup. Croup is tracheobroncholaryngitis. Okay, it's inflammation of the trachea, the larynx, and the bronchi. Okay, usually has a barking cough and hoarseness and loud breathing and stridor. Okay, because of the inflammation of the larynx. That's why you will have this barking cough. Larynx is inflamed and hoarseness, and it can cause difficulty breathing and stridor because laryngeal spasm, bronchial spasm can lead to this difficulty breathing. Okay, and dexamethasone is a drug of choice for children. All right, so number one, we diagnosed it. Number two, what do we want? We want to know the mechanism of steroid receptor or corticosteroid. Corticosteroid. I have to say corticosteroid to mean that whatever is secreted by the adrenal cortex. So corticosteroids are analogs of cortisol. Okay, corticosteroid receptor. We want to know the mechanism of corticosteroid receptor. Okay, what do we need to know about corticosteroid receptor? Number one, corticosteroid receptor is a cytoplasmic receptor. Cytoplasmic receptor. It's not a cell surface receptor, and it's not a nuclear receptor. Cytoplasmic receptor. And corticosteroid receptor have about 3 areas or 3 domains. Let's identify these domains. So that's the 3 domains. Okay. I think we discussed this previously in the previous question, but it's so again, it will have DNA binding domain. Okay, it will have hormone or steroid binding domain, and it will have transcription factor binding domain. So DNA binding domain, this area binds to DNA, and this area binds the steroid hormone. And this area will bind transcription factor. Generally speaking, a steroid hormone receptor comes in pairs. So when 2 hormones bind to each receptor, the 2 receptors will dimerize and attach to each other, and then we'll go to the nucleus. Maybe I should do this. This is a cell. Okay. So this is a cell. The steroid hormone is made of cholesterol. So in this case, it's dexamethasone. I'll put S. I'll just put steroid. Steroid goes diffused directly into the cytoplasm. Why? Because steroid hormone is made of cholesterol. Cholesterol is soluble in lipids. Cell membrane, plasma membrane, and nuclear membrane, they're both made of what? Cholesterol and phospholipids. So steroid is soluble, fat is soluble in fat. So it can directly goes into the cytoplasm. And there, the steroid hormone, let's say this is the steroid hormone. These are the steroid hormones. It goes into the cell, and there they will find their receptors, and the receptors are, let's use red. This is one steroid receptor, and this is another steroid receptor. Okay, so when they go into a cell, the steroid will bind to its receptor. I'll put R in there so that way you know this is a receptor. So when steroids bind to this receptor, what happens? There you go, one steroid attached, another. These two, when this happens, the steroid receptors will dimerize. Dimerization means they come together. Maybe I can use this. Let's see. Okay, there you go. The two receptor will dimerize. This is called dimerization. So dimerization will lead to this, and now these receptors are activated. Without the steroid hormone, they are inactive. Once they are active, they bind to DNA sequence. They will go into the nucleus. So then they will travel into the nucleus. Once they bound, they go to the nucleus, and then they go attached to DNA. And this will cause transcription of DNA to mRNA. And then mRNA in the cytoplasm made into proteins. So this is the general mechanism. Okay. But anyways, we need to know simply that this is the mechanism. So the protein that are produced by these proteins can stay longer. So the half-life of the protein is probably longer than the steroid hormone. Okay, so in essence, even the steroid hormone was taken once, dexamethasone was just taken once, but then its effects are to make new proteins. This protein will cause some physiological function. So half-life of dexamethasone is less than the steroid. I mean, dexamethasone is less than its product. What is its product? Proteins, right? So that's what the protein will keep doing whatever it needs to do to fight off the the infection. In this case, the parainfluenza virus, right? It's the parainfluenza virus that causes croup. Okay, let's look at our choices. Now that we understand to some degree what's going on. So dexamethasone receptor catalyzed formation of stable tyrosine phosphate bonds. No, tyrosine phosphate bonds. Look, tyrosine kinase receptor. So this is talking about tyrosine kinase receptor. A. Tyrosine kinase receptors have to do with insulin. Tyrosine kinase receptor have to do with insulin. Okay, so this will be talking about insulin. Insulin, not dexamethasone. Once the tyrosine kinase receptor, so once insulin attaches to tyrosine kinase receptor, the two receptors are cell surface receptor, not cytoplasmic receptor. They'll dimerize and then go through autophosphorylation and then do its effect. So unlikely. So A is not a choice. Number one, receptor tyrosine kinase receptor is cell surface receptor. Number two, it's for insulin. It's not for dexamethasone. Competes with beta arrestin for binding of adrenergic receptor. Adrenergic receptor, we talked about it previously. Or G protein receptor. They're G protein receptor. Okay, so like for epinephrine and so forth. These are cell surface receptor called G protein receptors. They are not cytoplasmic receptor, and they are for epinephrine. Epinephrine. Look at the adrenaline. They tell you adrenaline. Okay, epinephrine. It's not for dexamethasone. Couples to G proteins with low intrinsic GTPase activity. Again, this is talking about G protein. These are cell surface receptor. So I'll just put cell surface receptor. But the mechanism of action of dexamethasone receptors, it is cytoplasmic receptor. So C is not the answer. Depletes cellular stores of glutathione and NADPH. Okay, glutathione and NADPH are molecules or reactants that gets rid of free radicals, and acetaminophen can increase their concentration and cause damage to the liver. So the drug that can help with this is acetaminophen. Okay, so not dexamethasone. Induces protein that remains functional after the drug is eliminated. Yeah, so steroid hormone, it binds to its receptor in the cytoplasm, then it will cause transcription of DNA followed by translation of mRNA into proteins. So the protein that are produced can remain longer and still do its function. So yeah, E is the best choice. Okay, all right.